to our short lecture on Chapter 7, which is Health Policy and Regulation. In this lecture, we'll be talking through health policy and how it impacts organizational behavior, and specifically how health policy is an important, ever present element in what we do. Now, we're going to introduce some key regulatory challenges that we face as healthcare organizations. We're going to talk about a few specific laws that healthcare executives grapple with, especially when they're thinking about the structure and design of their organizations. We'll also talk just a little bit about how regulations are formulated, both internal to the organization and externally. And so when we think about health policy and regulation, we have to think about the healthcare industry very holistically, right? So across the United States, we have this large set of systems and organizations working together to provide quality healthcare services. Now, one component of that is, excuse me, one component of that is regulation. So the government regulates everything that we do in health services organizations, right? They regulate the quality of care provided. They regulate the financial reporting. They regulate staffing and operations. There's laws put in place at the federal, state, and even sometimes the county and city level to a lesser extent to help us deliver quality services. Now, these policies and laws are intended to help us increase access, control costs, and improve quality, but they also can serve a social services function. Maybe it's about working with certain populations. Maybe it's about making sure that our footprint, what we're doing, is sustainable in the community, environmentally even. Now, federal agencies have a tremendous amount of oversight in health services. And I love this graphic. If you expand on it, it's just how policies are made, how laws are made. But the two main federal agencies that are involved with the quality of care or regulating care are primarily the Center for Medicare and Medicaid Services and, of course, the CDC, Center for Disease Prevention and Control. Both of those are components of the Department of Health and Human Services. So the Department of Health and Human Services includes all these different agencies that both provide and regulate care and pay for care, right? Like Medicare and Medicaid. And then it's important to realize that all of those agencies are under congressional oversight. So again, when we think about politics and power and those dynamics, the funding is controlled by that changing political landscape. Now, there is a tremendous amount of bureaucracy in federal government. And bureaucracy really means that there are defined processes that require certain steps, and that because of that, things can move slowly. Now, your textbook calls out a couple key agencies. Here we've got the Department of Health and Human Services, which we know includes a lot of divisions that we're going to see on the next slide. It includes the CDC and the Agency for Healthcare Research and Quality and the Agency for Aging. We also have the Department of Veteran Affairs that provides care to veterans via networks of integrated health services, right? So hospitals and clinics. And then even the Department of Defense does a lot of health services work and direct delivery of care when you think about care being provided to military folks and their families. Now, here's a few agencies that are part of the Health and Human Services. Just a few. We've got the Administration for Children and Families, the Administration on Aging, the Agency for Healthcare Research and Quality, the Agency for Toxic Substances and Disease Registry, and the Center for Disease Prevention and Control, or Control and Prevention. These agencies all have different functions, but they're all part of that greater umbrella of the Department of Health and Human Services, right? So we're serving children, we're serving the aged. The Agency for Healthcare Research and Quality deals with the reporting of quality metrics and making sure that we're vetting physicians and we're aware and really making sure that people aren't getting hurt and that if something bad does happen, that it's reported and managed. Of course, we've got toxic substances, which we know that's like the 1-800 line that you call, right? When poison control, when there's an issue. We also know that that's research around toxic substances and diseases and tracking. The Center for Disease Control, many of us know what that is really well because of COVID now, right? But the agency provides regulations and assistance and support and training for dealing with epidemiological and health-related issues. We've got the Center for Medicare and Medicaid Services now, who pay for a lot of health services in the United States healthcare system. The majority of services are to patients with Medicare and Medicaid, if you look at the data. And so they're a huge player in that landscape, and they deal with the certification and accreditation of healthcare facilities. Even though they may not be the ones accrediting, they're the ones who are granting that ability. We've got the FDA, Food and Drug Administration, which we know is making sure what we eat is safe, but also any medical devices, any pharmaceuticals are approved through their processes. We've got HRSA, which is the Health Resources and Services Administration, and I actually work with HRSA now. I'm a principal investigator on a HRSA-funded grant trying to expand rural health services in the availability of services and referral to social determinants of health-related services like housing and food services in rural Appalachia. So they fund a lot of community clinics, a lot of HIV care, really great organization to work with. We've got the Indian Health Service, which of course provides care for Native Americans, indigenous populations here in the United States. We have the National Institutes of Health that funds a lot of research. And then the Substance Abuse and Mental Health Service Administration that, again, I talk about them in some of our other lectures because they do so much great work and there's so much great data around mental health awareness, around family and social life impairment that you can get access to. Anyways, they collect a tremendous amount of data, but they also fund programs for mental health and for substance use reduction. Now, you'll notice that name, substance abuse, we don't really use that term as much anymore, right? We've moved towards substance misuse and other terms, but you'll notice the naming of agencies, that takes a really long time to change, if at all. And you'll notice that with Indian Health Service, right? They're keeping IHS, but I wouldn't be surprised if at some point that got rebranded at some point. All right, so federal health bureaucracy. I already said we have the Veterans Administration that provides healthcare services to veterans, and then we have the DoD, the Department of Defense, that provides TRICARE, which is the service that provides health insurance to current and retired military personnel and their families. So that's the insurance through the DoD. Also, there are military hospitals, right? Military clinics that are available to those individuals. Now, the next slide provides a list of these agencies that I've just discussed for you. And if we go here, that's the end of that list, we've got a list of little acronyms. And you'll notice there's one at the corner that has lots of logos and then a bigger one. All of these are agencies that are part of the federal government that touch health. Now, you may say, I don't understand. How does NASA touch health? How does the National Science Foundation touch health? It does. And so we can look at that. But if you're thinking about career opportunities, I have a friend, for example, right now that works for the Department of Energy in DC, right? But he is an industrial hygienist. He has an MPH, a master's in public health, and has a background very similar to what you might obtain with an undergrad in healthcare administration. Now, there's a lot of oversight for federal agencies, and the bulk of that oversight comes from administrative procedures. So when a law is enacted, it often, whether we realize it or not, and even if it's 800 pages, it's often very vague. And so there will be these notations made, things like, for example, when they first passed the change to move from an old coding system for medical records to a new one, ICD-9 to ICD-10, there was this language in the law that said the Department of Health and Human Services will write related recommendations. So they didn't even say how it would happen in the law. They just said, do the thing, and the Department of Health and Human Services will write the procedures. They'll write the administrative law and requirements. They'll write the nitty-gritty pursuant to Section 8.2. That is an administrative procedure that goes under the law. So quite often those things are being written by the agencies and adopted over time. Something to keep in mind. The graphic that we have here is components of the United States public health system. And so you can see at the top, we have federal agencies, but then we have everywhere else you might be working if you're working in public health or with health policy. So a lot of different career paths, a lot of different opportunities. Now, this is not a finance class. This is not an insurance class, but just so that we're on the same page, I want to go through a couple of the fundamentals before we talk about specific health policies. For example, Medicare. Medicare is the federal health insurance program for elderly and disabled. So if you are 65 or older, you've been disabled, 65 or older, or if you're under 65 and you've been disabled for 2 or more years, or if you have end-stage renal disease, you're on dialysis, or if you have Lou Gehrig's disease. Those are the 4 categories now. It's been expanded. Those 4 categories are eligible for Medicare. Medicare tends to pay physicians and hospitals fairly well. It's a decent insurance to have. Medicaid, which is a federal program that is then ran through the states and ran differently, some states handle it almost fully independently, is for lower income individuals. There's an income eligibility test to participate. That insurance typically does not pay physicians or hospitals very high. And so when you hear about complaints about government payers, we are primarily talking about low reimbursement rates from Medicaid, which provides insurance for individuals who are low income, not Medicare that provides insurance for the elderly and the disabled. Now, the Medicare and Medicaid systems primarily, and different states have different policies, but the federal Medicare program uses prospective payment system. This is where, and when you read that sentence, that title, prospective payment system, it sounds like you get paid in advance. Prospective. No, you don't. You get paid way later, often. You agree to a payment rate in advance. It's preset every year. So right now they're working on the 2025 prospective payment system. If you're listening to this today, right, with me. But they're working on that payment system, and they're getting everybody to agree, or at least understand, quite often we don't get much of a choice, what their payments will look like for the next year. So it's preset. The menu prices are preset, if you will, the reimbursement. Now, Medicaid used to require that individuals meet a categorical need, meaning it wasn't just that your income was low. So 20 years ago, for example, my income might be low, but I might just be a single male making not a lot of money. I wouldn't be eligible for Medicaid then. But now it is purely a means-tested program. So if you make below a certain threshold based on either being alone or based on your family size, you can be eligible. You don't have to be a mother with children. You don't have to be a pregnant woman. You don't have to be a child. Those things, or on Social Security. These were requirements that used to exist, right? And now with the movement through the ACA, Medicaid in most states is completely means tested, with the exception of certain special programs, we call them waivers, that have certain eligibility criteria. Now, there is a lot of oversight from Medicare and Medicaid. They will only reimburse healthcare organizations that have accreditation, and most primarily receive accreditation through the Joint Commission. They require that providers either are contracted with them or accept a different non-contracted rate. So you have to get contracted with Medicare. And Medicare has something called the MedPAC, or the Medicare Payment Advisory Commission, who makes all the decisions and advises the feds on how payments should change in the future. So there's a group of informed industry leaders doing that work. Now, let's talk for a minute about Medicaid in North Carolina. So this graphic is a few years old, right? This is taking us back almost a decade. As of this year, and as of whenever you're viewing this lecture, North Carolina has adopted Medicaid expansion. They have expanded access for those who have Medicaid. I actually have an interesting story about that in a minute. But we were at the tail end of that expansion. Now, many of you aren't in the state of North Carolina right now. Maybe you're traveling, maybe you're not from North Carolina. So every state is different. We'll see that on the next slide. But it's important to realize that if we want to guarantee access to care, states have the ability to accept additional federal funds to expand and offer more Medicaid. Now, you'll notice this number 626,000 people these were 2018 estimates, be eligible for Medicaid expansion. Could all of a sudden, if we expanded the eligibility for Medicaid in North Carolina, which they did, could now be on insurance. I was just on a meeting last week with some folks at the North Carolina Association for Free and Charitable Clinics, And they shared some data they have access to that says about 450,000 of that 626 have signed up, are now insured that were not before. So that's kind of interesting when you think about that trajectory over the last 6-7 years. Okay, so this is Medicaid expansion status, right, as of that same time frame, and this is through 2021. And if you're like, why are you showing me something old? We'll go to the next slide in a second. You can see North Carolina take over. So 2021, we haven't adopted yet, but you'll notice it's primarily the South and a little bit of the North Midwest that hasn't adopted yet, right? Primarily states that have more right or Republican policies, primarily states also, though, that have more fiscal conservatism and have more, I don't want to say vocal state government, but they manage their Medicaid programs pretty internally and don't rely on as much federal aid. So they're independent and they're managing it fairly well, at least from a fiscal perspective, right? They're able to manage it without asking for more money. That's common in states like Florida, where AHCA, the Agency for Healthcare Administration of Florida, tightly manages Medicaid. And I know that because I used to be a Medicaid plan director for plans in California and Florida. Very different policies in each state. Okay, so we've got 10 states left now. And if you look, there's a lot of work that's going on now in Texas, a lot of pushes that are happening in Alabama, right, to roll this out. But these are the states that have not yet expanded and said, we're going to let more people on Medicaid. We're going to increase our eligibility criteria a little bit. What does that even mean? What have I been talking about this whole time? So Medicaid expansion is a provision that was part of the ACA that says we can cover more low-income Americans by increasing the eligibility all the way up to 138% of the federal poverty level. So basically, you can make 138% of the federal poverty level and qualify for government insurance. Most states did not have as high a limit, right? But there are federal funds that can support that now, is the idea. Now, transitioning for a second, there's a lot of other policies that are important to be aware of when we think about org behavior. Things like food and drug law. So the FDA, as I said earlier, is responsible for ensuring the safety, the efficacy, the effectiveness, how it works, that there's no side effects for any medications, but also medical devices. There's a lot of regulatory challenges there because we as the public demand, give us what we need now, make the approval process quick, but make sure it won't hurt us. And so this is tricky, and making sure that we control the dissemination of information. We all saw this with the approval of the COVID-19 vaccine, right? There was a lot of back and forth there. Another type of law that's very prominent in Health Services Administration is antitrust law. And antitrust law says that we cannot merge together to the point where it restrains trade. We cannot create monopolies. And so in healthcare, we're really limited to the extent of which we have monopolies in certain regions. The state has to approve mergers, and quite often in some states they approve them all, and we have near monopolies, and in other places they don't. But the idea of less competition maybe being a bad thing for patients is why we have antitrust law, things like the Sherman Antitrust Act. We also have tax exemption law, right? And I'm trying not to go into specific policy names. You'll notice I'm kind of keeping it vague on purpose because I want you to think about implications, but I don't want you to feel like, oh, I have to memorize all of that for a quiz. Okay, tax exemption law. United States hospitals do not pay income tax on the money that they make. Now, I know income tax sounds weird, but they don't pay a corporate income tax. They don't pay property tax. They don't pay state or county taxes. They're free of tax except in some rare exceptions. And so they are making huge amounts of revenue. You can see an example here with a listing of Federal Form 990 revenue. So these are revenue being reported by not-for-profit hospitals. For example, Cedars-Sinai made $104 million above their losses in charity care and their operating expenses. That's a lot of money for a small hospital system to make. So there's some changes that are happening in this space. We're requiring more evidence from hospitals that they're providing community benefit, that they're doing good things in the community, because that's how it's supposed to work. I, as a not-for-profit hospital, do not pay taxes because I'm doing good things in the community, because I provide some charity care. That's the idea. So there's lots of other important federal policies things like the federal fraud and abuse laws that tell us how we're supposed to submit claims to the federal government, what is appropriate to bill for. We've got HIPAA, of course, respecting people's information, keeping it private, secure. We've got EMTALA, which is the Emergency Medical Treatment and Active Labor Act, that says that I can go to any hospital facility and demand that I be treated, regardless of my ability to pay, if I'm in active labor or if I'm in danger of death, right? They have to stabilize you. And so that prevents us from thinking too much about the financial while we're trying to stabilize a patient. Now, is that law violated in different ways frequently? If you've worked in a hospital, you know they're asking about the insurance information right away. Like there's those conversations. So this is kind of a sticky situation. And then we have the Healthcare Quality Improvement Act. And the Healthcare Quality Improvement Act is actually really interesting, which is why I have this graphic here. The Healthcare Quality Improvement Act created the NPDB, which is the National Practitioner Data Bank. It's a national database of all healthcare providers. So medical doctors, doctors of osteopathy, physician assistants, nurse practitioners. It has all their information and other types of providers and hospitals. So you can check. You can see if they've been sued and paid out a Medicare malpractice claim. Have they lost their license to prescribe medication? You can see all that. It's really interesting. Now, we just talked for the last little bit about state and local policymaking and health bureaucracy. About federal. But state is so important. Every state is so different. And I can't educate you on that today. I can't prepare you perfectly to work in Texas or California or New Mexico. I can tell you the norms and I can tell you what states control. So states control Medicaid. There are Medicaid offices so that insurance for the underserved, the low income, is through states. The federal money goes to the states manage the program. At a federal level is normally where the Medicare or the aging and disabled insurance happens. So they're different. And the Constitution gives a lot of powers to the state. So a lot of work happens at the state level, right? This is a link to the North Carolina Department of Health and Human Services website that talks about the work that they do. One of the big pieces of that is licensure. So hospitals in our state are licensed by the Department of Health and Human Services, the State Department of Health and Human Services, right? So they look at whether or not we are providing appropriate quality of care, but really meet very specific regulations. And they have the ability to shut us down, right? They license us. There's also a North Carolina Division of Health Services regulation that licenses acute and home care. So even home care services are under that. All right, so one additional law is certificate of need. And I like to talk about certificate of need quite a bit, so I'll keep it high level here. But if you have questions, I've been working on research in the space. I'd love to chat about it. Certificate of need programs in certain states, such as Tennessee and North Carolina, require that individuals submit for approval to the state before they build a new hospital or offer any large-scale services. So if I was going to build a hospital or a large outpatient center, I would have to get state approval first. And what's really interesting is every state's laws around this are a little bit different, but the states that require a certificate of need, demonstrating that the state agrees that this is a needed service. Some of the states, I know here in Tennessee where I live, some of the states require that you allow your competitors to rebuttal. So as you're applying to open a cath lab in a local city, your competitor can say, nope, that cath lab isn't needed. We already provide a lot of those services. So it's an interesting dynamic from a competition perspective. And every state's different around their policies. All right, so we know there's some relationships between state and federal law that get a little complicated. I think cannabis use is the number one question in Canada, the sale of cannabis, right? Is that legal? Is it illegal? Where is it legal? How is it legal? What do the feds say? What do the states say? In general, in healthcare, we have something called preemption, which means if federal and state laws directly conflict, we always go with the federal law. Now, there's different types of preemption, and both the state and federal law can have significant influence over what we do, but federal law takes precedent. Now, when we think about the work that we do as healthcare managers and the work we do to be in compliance with all of these laws. There are many requirements that are part of the laws that have been on the last several slides. Our priorities have to be to ensure patient safety, never just do something because the law says it, make sure we're keeping our patients safe. We have to hire, recruit, retain, grow an employee who is our compliance officer, who's engaged in the organization and helping us track these things. And we also have to make sure that we invest considerable money in compliance. So training individuals on what's appropriate, making sure all of the employees know the right laws. Not everybody has this education you have. A nurse may not know some of the specifics about EMTALA unless they're taught it, and sometimes they're taught it in the workplace versus in advance. All right, so this is a list of reportable events. So when you think about something that would happen in a hospital facility, that you would have to call the federal government and inform them. Wrong surgical procedure performed on a patient. An infant discharged to the wrong person. Oh my goodness, some of these I can't even read. An abduction of a patient, right? So these are our never events, the terrible things that happen. And these are tightly regulated. These are things that require federal reporting. I just wanted to throw that out there. Now let's talk through a couple recent policy and regulatory initiatives. So for example, there's a new initiative called CMS Price Transparency that says that patients know little about the price of the services they're receiving, and we have to start sharing that information. So hospitals are required to post their prices on their website. Now, some of them are getting around this by, instead of posting it, they'll post a web tool. So if you upload all your insurance information and you fill out a bunch of forms, they'll tell you the price of a service. But really the intent behind this is to have a large machine readable file that has every price for every service. Now, what I mean by price, we already know how much they want to charge us in many cases, in general. But these are negotiated contract rates, which means that, for example, if I'm a Blue Cross patient or if I'm an Aetna or a Cigna patient, we may be paying a different amount for the hospital stay. I may be paying $600 a night. You may be paying $4,000 a night. Hopefully not that huge of a difference, but you get my point. This requires hospitals to share that information, how much each insurance company has contracted to pay them for each specific service. Now, we're starting out kind of baby steps, so it's really only a smaller list of services right now, some that are mandated and some you get to choose from what you share. But this is the direction we're heading with sharing how much things cost. And pricing information will allow for patients to make better decisions and make sure that we're ensuring quality while still providing it at an affordable rate. Some other big movement in the health policy space is pay for performance. And this is linking financial incentives to accomplishment of goals. So we get paid more if we provide great care. Quite often this manifests in dings or decreases to our payment if something is suboptimal. If a patient gets a pressure ulcer or a hospital-acquired infection or any hospital-acquired condition, we'll be paid less. So that is part of pay for performance. Now, that also, and I hear this language less now, but that also is sometimes referred to as value-based purchasing. That's Medicare's language for pay for performance is value-based purchasing. And the goal of that, right, is to make sure that we're paying for good services. We're ensuring joint accountability. We're incentivizing good care. We're incentivizing smooth transitions between hospitals and skilled nursing facilities. Now, there are other types of organizations. I tend to focus very closely on hospitals that have special laws and expectations, such as specialty hospitals. Specialty hospitals can be very controversial because they provide services to a certain group, maybe surgical services to folks who can afford really expensive, nice surgical care with extra space in a room. They may be providing elective services, right? So these organizations have caused some concern in the political landscape because if I'm a hospital that's trying to survive, but all of the expensive procedures, hip fractures, cardiovascular procedures are going to that fancy specialty hospital, and all I have is uninsured and underinsured patients and costly services to provide with low reimbursement, it could threaten me as a community hospital. All right. The last few slides here talk about policy challenges. This is a graphic I encourage you to come back to another time, but it just shows how many people are involved with how a law is made and how corporations and other groups are engaged in many ways. So, current health policy challenges. There are many different challenges that are currently facing us. If you look, we discussed, I think, about all of these with the exception of COVID-19, right? Which, of course, is a challenge for many reasons. When I think about supply chain, prevention versus freedom. I can't mandate someone quit smoking, but then do I have to mandate the population pay for that person's care? That public health dilemma gets complicated, right? And then, of course, we also have to think about the payment mechanisms. Lots to think about. All right. I want to leave you on this slide, which is just some discussion questions to consider. What are some of the major advantages and disadvantages of the way that we have so many laws and so much regulation and we make it in a democratic system? And how does that impact how organizations are ran if we're constantly environmentally scanning and adapting to new laws? So just some thoughts to consider. Thank you so much for joining me today. Have a good one.